have while we all get together. But we are pretty much on time, ready to start. So I really want to thank the panelists for being here quite on time and really willing to share their experiences with us. So, well, good afternoon. My name is Juan Carlos Negret. I'm Director of Global Health at the University of Utah. It's a pleasure to have you here. And this is a conversation that we started some time ago, and regarding the urgent need to support healthcare workers and well-being and resiliency. So, but not just remaining in the areas of diagnosing the situation, diagnosing the problem, but also being aware of something and also acting upon it. So that is the intent of this conversation. And just the rules of engagement. I'm going to be a bit stringent in the use of time. And in doing so, we will have to manage also the expectations of the audience. One is we're going to select a couple of questions every time that will have the possibility of having interaction with you. But we also plan to ask you questions. We know that every one of you here is an expert on its own right, and the idea is that the conversation that we have here in one way or another gets registered for us to turn this conversation into an editorial piece that we can share with others. And we really want to reach to a much larger population. So I will start by introducing our panelists. I will start with Catherine Kane. Thank you, Catherine. She's the Technical Officer of the WHO Health Workforce Team here in Geneva, and with a portfolio that includes global health and care workers compact. Prior to WHO, Catherine worked for the Red Cross movement locally, nationally, internationally, and has held additional policy and humanitarian diplomacy, public health, and emergency management positions in government agencies and health advocacy organizations. We have Dr. Shabnam Sarpras. She's the Global Director in Gender and Health Women in Global Health. And so her role is in global health. And for those of you who I think you all know what Women in Global Health do, but in case you do not, this is an organization that focuses on promoting gender equity, of course, but also equity in increasing the percentage of women working in leadership positions in the world. So that is one of the particular focus of the organization. They work in 52 countries and around the globe, and she has worked also for the Federal Planning Commission in Pakistan. And she was the national policy and planning lead for the health, education, youth, and gender portfolios. She also led the government of Pakistan response to the COVID epidemic in 2020.
It started 2020.
Okay, thank you. So we also have here Dr. Anthony Rancho, and he's the Regional Medical Director for Europe and for International SOS. He's based in London, and he has an interesting set of hats. He's also as Chief Medical Officer in a number of organizations. He advises on public health, remote healthcare crisis management, pandemic planning, and corporate health. So he represents here in this team the private sector view of the response to the crisis. He has worked all over the world, and he has a particular interest in the complex interplay that exists between the global health and the private sector. We also have Dr. Aisha Malik, and she is the mental health specialist in the Department of Mental Health and Substance Use in WHO. She specializes in global mental health, covering international and national policy, developing technical products, and also research and strengthening the capacity of countries in addressing mental health care. She's the lead of the workplace mental health. And she published the WHO first guidelines on mental health at work, and currently she's developing a training for general managers to better support employees' mental health. So quite relevant for our conversation today. And finally, we have Dr. Awar Hani, and She's a doctor from I tried to pronounce it, Qasr Al-Aini University in Cairo. She is currently serving in the International Federation of Medical Students Association, and she's the liaison with WHO. She brings a perspective of about this particular issue from the students inside of the education. So just in order to explain a bit our conversation today, I just wanted to share with the audience that we actually started we had a similar session last year, and we had pretty much a similar set of organizations present. So at that time we had Ruth Badat as the representative of the Women in Global Health, and she was quite instrumental in putting this in advancing this conversation. She brought a quite refreshing perspective on gender and health, which is, yes, you know about it, of course you do know, but both the articulation and the idea of how can you actually act upon it it has a distance that has to be actually covered. So in that sense, we also had Dr. Dia Tadese as providing a framework for the conversation from the implementation in the public sector perspective. We also have a representative from private sector here from Hospital Universitaire de Genève, and we continue with that tradition here with Anthony, and also we had someone representing an INGO. Her name is Tracy Bird. She cannot be here today. She wanted to be here today, so she's here instead. So what we're going to do is to take the 4 points that we wanted to that we started discussing last year, and seeing what actually can we do with that today, and how can we move forward. So first of all, there was an awareness and definition of the HR burnout and well-being crisis. And the question here is, if in doing that, if that formulation is it leading to effective policy formulation? Does it suffice? Of course, usually those very short approaches do not. But in the conversation, this definition is helping us to achieve what we are aiming from the policy perspective. Second, it's academia working in multilateral is working with multilateral organizations and NGOs in helping understand the nature, root causes, and impact of the problem. This is kind of my personal perspective on this. I come from an academic health center, and we do have expressions of the problem. We're conducting research, but we are not necessarily talking to institutions like the ones that are sitting here. Is that a missed opportunity for us? Perhaps it is. Most likely it is. So are we addressing the problem from a multi-sectoral perspective and considering solutions and implementations accordingly? That is the other element that we wanted to cover in our conversation today. And finally, how holistic are the solutions proposed? It's from the gender, professional developments, and perspectives, and also understanding. And here's a bit of my fingerprint. Understanding that complex problems cannot be effectively addressed by having a dichotomic approach to them. So, for instance, the private-public divide doesn't make sense when you understand that the conversation is usually very fluid. So, with that, I think I will ask our friend Kathleen to please set the conversation dynamic by having a presentation precisely on the global healthcare compact that she so aptly helped to develop.
I'll just stand up so I can glance a little bit back. We'll go right to the next slide. So the Global Health and Care Workers Compact is an outcome of COVID-19. We were asked in the World Health Assembly through, go on to the next slide, World Health Assembly Resolution 74.14 to develop a technical compilation of international laws, treaties, and other legal instruments related to human rights and humanitarian rights. We were also supported through the UN General Assembly 74, Declaration on Universal Health Coverage. So as you see, and go to the next one, this is just some language, but language always sets the stage for what I want to do next. So over the following year, we conducted an intense review of international laws, treaties, and instruments, as well as consulting with professional associations. Here are all the people that we talked to. We talked to internal WHO units, some of whom are represented here. And then we went back to member states, to governments, and said, this is what we've come up with. These are the recommendations, the management actions, the political leadership that is needed to make this come to fruition. And we presented it right back to them as a technical support document in the following World Health Assembly. So go ahead. And so then we came up with World Health Assembly Resolution 75.17, which established 4 domains and 10 areas of work related to ensuring the rights of healthcare workers were protected, so that they in turn could help us realize ambitions for universal health coverage and recognize their own human rights, their own right to freedom from attack, to social security, to freedom of conscience. And what we came up with at the base, you'll see very nicely, labor rights are human rights. And we'll have another slide or two, as well as a nice link to the CARE Compact that will be available for download. So if we are looking at fulfilling the population's right to the highest attainable standard of health, anybody source? WHO Constitution. We started this in 1948. Then we have to ensure that we are taking care of the human component that are at the core of providing services. Go ahead. And so what does it entail? The 4 domains: preventing harm from occupational hazards, from violence and harassment in the workplace, and during situations of fragility, conflict, and violence. Next, providing supports. This is through fair and equitable compensation, which is also known as decent work, social protection, enabling work environments, occupational health services, and mental health resources. Next, we have inclusivity. Go ahead. Safeguarding rights, we'll skip right over to that. This is whistleblower protection and the right to unionize and to collective bargaining. So you have the right to join the group of your peers and advocate for your working conditions without any fear of retaliation. And last, we have inclusivity, and I know that our friends here who are interested in gender issues are certainly going to pick this up. It's equal treatment and non-discrimination, and that goes beyond gender and also talks to disease conditions, origin, practice, goes through the whole gamut, because this is based on humanitarian and human rights documents. Next. And what's next? So over the past year, we've been having a lot of fun with the O'Neill Institute for International Health Law at Georgetown University. They have developed, in coordination with WHO, a health and care workers law and policy portal. It is exciting, and it's only the start. We're actually looking to build this forward. It's a collection of resources to support states in both self-assessment through a series of signal indicators, and to then examine what their environment is and take the additional resources that are normative guidance from WHO, as well as select other documents from ILO, from OECD, to strengthen laws, policies, regulations to ensure that we are protecting the rights of care workers. So we're looking at how to get this is what we want. How do we get this into the hands of countries? How do we get it into the hands of students? How do we get it into the hands of academic institutions who are creating the doctors, the nurses, community health workers, the pharmacists, the dentists? I hope I haven't forgotten any specific profession in the room. But how are we equipping young people to know what their rights are? How are we equipping various actors with the specific interests in each of the areas of work to advocate, to gather with the Ministry of Health and advocate? How are we supporting people to do case studies that look cross-country context, and then to do knowledge sharing? Go ahead. And this is our new policy. We will be adding more so far. We've got a desk review that covers 163 countries. And this is desk research that says this is what we have found so far. We're using the joint evaluation approach, the JEE approach, where we say yes, no, partial. There's actually interesting science that suggests that if you give people 5 options, you generally won't get a 5, or you generally won't get a 1. People tend to go 3 or 4. Or they'll just go 5, 5, 5, 5, 5. So this is why the 1, 2, 3. Are you totally doing it? Are you totally on board? Are you not doing it at all? Or are you partially on board? So what this does is creates an avenue for strengthening in the future. Okay? And here we are. You can leave them sitting right on here. You have your handy dandy 10 domains, 4 areas of focus.
Well, thank you very much, Catherine. That was a very quick presentation, and thank you for that, but also very rich at the same time. This sets the stage for us to ask questions to the panelists regarding some of the areas of expertise, of course, but also building on what has been already discussed and presented. So I have a question for Dr. Chapman. So Women in Global Health recently published its report on the Great Resignation, why women and health workers are leaving. And we know that, we experience that every day. What are the main lessons you extracted from it while putting it together? And from a gender perspective, what do you see as the most challenging areas, and where do you believe we have the greatest opportunity for it?
Thank you so much. Thank you. And this is such an important conversation. Migration has been there and it has been growing, and it has been a long-standing phenomenon, which is shaped by the labor market forces, which include education, working condition, remuneration, differences which are there in the countries for health workers, and it is exacerbated post-COVID-19. Women, they constitute 70% of the health workforce. So I think it gave us an opportunity to study based on secondary data as well as some of the primary data collection that we did across our country chapters and across using different forums. And the gender non-conducive work environments, the gender pay gap, exposure to violence and sexual harassment, and also unequal career advancement opportunities. These are some of the key factors which accentuate the women, from migrating to other countries. So some of the reasons, as I said, I think I'll just elaborate onto them, the difference in remunerations that they see in their home country and in overseas countries. Again, it's important to see that what they experience is also dependent on the gender dynamics within the countries which vary. So countries which rank lowest in the gender parity, we see the issue more in there. So like in a country like Pakistan, which ranks amongst I was with the AMRO team yesterday, and majority of the countries are concentrated in the lowest rank on the World Economic Forum Gender Parity Index. And this intersects down to the health workers also. The health workers make up 70% of the health workforce, and the female health workers. So amongst doctors and then nurses are majority, females, we know that community health workers in many countries, they are 95% plus are females. So overall, it's a figure of 70%. And what we see is only less than 25% in leadership positions. But again, in countries where the gender parity ratios are not very good, we see even less, like in a country like Pakistan, we see 5% in leadership position. Again, the gender pay gap is in the health sector, it is much worse as compared to other sectors, where it is 16% for overall, when we look at other sectors. For the health sector, it is 24%. So that's again one of the reasons which makes the difference between home country and other countries where they want to migrate, again as an attraction to that. The working conditions, and they are perceived to be significantly better. They haven't experienced how it is in other countries. So I would say it's the perception, and also, the experiences of others of their fellows who are in there, and better facilities for self, family, favorable working conditions, fewer working hours to achieve the work-life balance, which is much more important for female health workers, as they have so many, I would say much more important in the sense, because they're juggling with too many responsibilities, domestic responsibilities, with less sharing in low middle income countries as compared to, in the developed world, when they get more support from their partners. Again, I think the quality of life, overall standard of living, personal safety, the quality of education and health systems, and the general well-being. I think another important thing is the unequal opportunities for career advancement, unequal opportunities that we've seen in some of the surveys we've conducted in countries that they feel that they haven't been given equal opportunities for training, for career advancement, and they feel that it will be much more conducive if they migrate to countries where they perceive it to be much better in there. So it is actually one of the things is the limited support that they get in their home countries for professional growth and their perception of it being better in the developed world. I think there are uncertainties within the countries, and that would be not only within the health sector, but your socio-economic, your geopolitical situation in there, which again makes the health sector uncertain, and their job security and also the economic conditions, which one is that, and then after COVID, the demands for the health worker has been much more, and the policies to induct health workers from other countries have also been laxed by many countries, and that's again something which is making it more attractive for them to travel abroad and to be able to do that. I think moving on to, I think one of the things that we also studied in some countries was the burnout. So there was a report which we went through several of the documents, and also what the professional organizations had published. So Canada had, they documented in 2020 during the time the COVID started, a burnout of 30 to 40%. Australia had a burnout of 61%, and a recent study that we conducted in Pakistan had 78% burnout in the doctors that we sampled. And another meta-analysis of 30 studies from mainly high and middle-income countries, they found the prevalence of burnout among doctors and nurses as 66%. So it is a phenomena which is there, and we need to see that what are some of the factors which can help that. So now what can be done about that, So there are some examples that we can pick from the private sectors and the other sectors, Like one of the McKinsey survey, which was conducted on 30,000 employees across 30 countries, found that employees who had positive work experience reported better holistic health and are more innovative at work and have improved job performance. So we need to replicate some of these findings also, for the health sector here. As there are factors which are at individual level, at team level, at job level for this holistic health. So the interventions need to be entertained at all these levels. It's important to have disaggregated data to make you understand what is making the workplace, unattractive for them. What are the reasons behind migration? What are the things which they perceive as stresses in their home country, which organizations themselves could also be able to, address that, like violence, which is, something which is widespread. So I think it's pretty complex, but it is also, there is a need to understand it better, both at the country level, both at the organizational level, so that we are able to come up with policies and programs. And one of the things in the end, I would just want to say that for gender-conducive work environments, for female health workers, it's very important to have women at policy and decision-making level, both in the organizations as well as as well as at the health workplaces, because like maternity leaves and the challenges of not having daycare centers or transport facilities being not there, for women to travel in for work. So these are some of the things that they need facilitation with, and also flexible working hours. So many of these reasons, and again, I would say it's the perception that they carry that these issues are not there in the developed world. It's something that is really making them.
Well, thank you very much, Dr. Shannon. And clearly that is an area where there's a lot of improvement to be done, but also that advancement has been. So I'll go ahead and ask Dr. Renshaw, as an organization that both works and employs thousands of healthcare workers around the globe and advises companies on mental health and well-being, what learnings do you think global health policy makers and health leaders take from the private sector? And can you explain the private sector isn't to you in this area, and it's your definition at the moment to limit it.
Thank you very much, Carlos. So let's start with the final question. Is our definition of private sector too limited? Yes, it absolutely is too limited. The definition, I think, really in this space is largely around healthcare, providers of healthcare in the private health system, whereas there are some great examples from the wider private sector of how to make a pleasant, safe place to work where people can thrive, that I think we could take some good examples from. Now, when we look at the best practices around the world, and we're privileged to talk to multiple companies across all industries around the world, we can split them, broadly speaking, to 3 categories. There are the core category. Those are those organizations that comply with regulations. They do things just so they don't get into trouble with the Health and Safety at Work Act, etc. Then there's the other group in the sort of in the middle. We call these the essential group. They would be the ones that will be using best practice standards and guidelines like the ISO 45003 and others to get to a better place than what they have to do by law. But then beyond that, we have a group of organizations which we call in the blue zone, which are doing way more than that. And they are using mental health and well-being in the workplace as a lever for sustainability. They write about it extensively in their sustainability reports, and they incorporate that in their GRI reporting, etc. And it's that group that's really fascinating. How do they do that? Now, when we look at some of these examples, you may think, well, how does that apply to me at policy level across multiple countries, resource pool settings, etc. Actually, some of these learnings can be applied across any setting. And I think as a healthcare worker myself, and having worked in the state sector, I can see abundantly why some of these issues are taking place. And it really is around really trying to make our healthcare workers' needs meet the needs of the organisation. And if we look at it as a sort of triangle based around Maslow's hierarchy of needs, right? We've got our, and that can be critiqued in many ways as it has been. But on a basic level, are we providing our staff with a safe place to live and work, to travel safely to work? Is the nurses' accommodation leaking from the roof, etc.? Are we paying people on time? One of the reasons why we've been successful in delivering healthcare around the world in the challenging places that we operate in, and we would operate in everywhere from Afghanistan to Kazakhstan and Somalia and everywhere in between, is our ability to pay people on time, make them feel respected for the work that they're doing. The core thing, and this has been proven in a number of our studies that we've done with some of our academic partners, is inducting people properly, making sure they know what they're doing, so they're not faced with turning up to a site or a clinic with nothing there. They don't know how things work. Now, this is not just the case in rural parts of the global south. I have faced that as a locum doctor turning up to an NHS hospital as an SHO. When I was in my junior years, I didn't know what I was doing. I had no idea. I didn't know the computer system. Nobody really cared about me. So I think until we sort of change that approach and look at that, then it's going to stay the same, really. Now, when we've also looked at a number of groups of workers in studies we've done with our partners, including Affinity Health at Work, who are specialised in organisational psychology in the workplace. We've done a bunch of different studies on rotational workers, hybrid workers, and people who work for travel. Now, in our world of rural and remote healthcare, quite a lot of our healthcare workers fit in those buckets. And there are a few key observations here when you are staffing people in such challenging places that come to the fore. One is job control and autonomy. That's a central protective factor. We see this time and time again when we go out to corporates. They have exactly the same issues as we do. Can we somehow change the way in which they deliver their work so they feel like they have some skin in the game and some autonomy? That's pretty clear. We also have needs that we've identified in terms of the protective factors against burnout. They seem to be pretty linked to the manager that you have when you turn up to your site, right? So until we fix that, people will be burnt out, and until health leaders understand that, it's going to be a challenge.
Thank you very much. That's really illuminating. Yeah, I think there's more to have in conversation on that subject. I hope we continue that after this. I have a question for Dr. Malik. So you published in WHO first guidelines on mental health at work, and you are currently developing the WHO training for general managers. Very well that, and to better support employee mental health. To what extent training programs development has resulted in an effective change of behavior in managers, and what has been the impact of on their employees?
Yeah, thank you. Good question. The first thing I want to dive into is, what do we mean by a manager? And fundamentally, we're talking about anyone that's responsible for supervising another person in some way. And whether we're in the health sector or outside the health sector, we're not just talking about team or department leaders, we're talking at other levels below that as well. So we're talking about a huge number of the workforce who are responsible for supervising others. Now, the big problem that we have, especially in technical specialist fields like health, is most people are promoted into these positions because of your years of experience on the job, or because you're really good at your job. You're not promoted because you're a really good supervisor or able to lead other people. So the issue that we have is we're putting people into leadership positions of other members of the workforce without them being remotely equipped to do it. So manager training for us when it comes to mental health specifically isn't what you might be hoping I'm going to say it is. It's not about let's make people fantastic leaders. That's leadership training, and that's still important, and that needs to happen. What we're talking about is, can you have the skills to communicate compassionately, effectively with your team or the person that you're supervising? Do you have some basic knowledge in mental health and what that looks like? Do you understand the risks that are affecting your supervisee's mental health? And do you know what you have to do as a manager to adjust those risks? And if you have an employee with a mental health condition, do you know how to actually support them? Because 1 in 6 working age adults has a mental health condition. So we are inevitably going to be supervising people living with mental health conditions, or we ourselves are going to have one in our lifetime. It's not a concept that we're going to not encounter, and people just aren't equipped to deal with this. So as a piece of work that started ironically, just before the pandemic kicked off, we wanted to look at the evidence for what actually works in workplaces when it comes to mental health outcomes, and not just for people's mental health, but what also affects things like productivity, absenteeism, and other aspects of job performance. And we wanted to look at the evidence because many people have a lot of ideas about what we should be doing in workplaces. And many people are selling programs about what we should do in workplaces, but the evidence behind them isn't very clear. So we were like, right, that's our job. We can do public health. Let's take a look at the evidence. And what we found was that manager training for mental health was very effective in improving managers' knowledge about mental health. It changes stigmatizing attitudes, and that's a huge issue in workplaces, especially in the health sector, because we are afraid to speak up when we're experiencing problems, and it changes their behavior. And their behavior means it made them more likely to actually support employees. Now, what happened when your manager went through such a training is you as an employee were then more likely to seek help if you needed it. And that's what these trainings do. They're not going to radically alter your mental health. They're there to change people's behavior so they go get the help they need. Because a manager is not a mental health professional, nor should they be. They're not going to be a counselor. They're not going to support you through every aspect of life. You ultimately need to go get the help. So that's what the evidence shows it does. But it's not the only thing that came out of the guidelines. So it's speaking to what others have mentioned, organizational interventions, tackling those risk factors that people face at work, whether it's issues of job control, high workload, issues with parental leave, so all these things that are impacting your stress, inequities. If you actually tackle that and you tackle it in a participatory way, including your employees or the employees it might affect the most, that's having a positive impact on mental health. Things like stress management interventions, the sort of mindfulness things that we're aware of, yes, they work. But when we did a survey of health workers' values and preferences and other employees, guess what everyone is saying? You know this. Don't just be giving me a stress management intervention if you're not going to make changes at the organizational level as well, because it's like putting a Band-Aid on a wound that actually needs surgery. It doesn't help. But the big issue that we face with health workers is there are a lot of gaps in the evidence. So the idea of reasonable accommodations, which is something that we're entitled to under the UN Convention for Rights and Protections with Disabilities, we don't know how do those accommodations get effectively applied in the context of you having quite a senior role, for example, as a health worker. How do we actually apply accommodations? What do we do when it comes to manager training when we have this huge issue in health where most managers are of one gender or sex and most people working for them are the other? And our evidence was also showing that younger workers or newly qualified people don't respond to some of the interventions in the same way. So there are gaps in what works for who. I'll stop there.
Thank you very much, Mr. Malik. So in our chain of questions in this conversation as it starts, I have a question for Dr. Arwahani. She represents the student body, so the question for you is the WHO acting to promote the transformation of medical and health education programs so they help students acquire the elements that they need to anticipate and manage emotional and the emotional and mental health crisis?
Can you say the question again, please?
So, sorry, I was pretty not very good in asking this. So is WHO acting to promote the transformation of medical and health education programs so they help students acquire elements to anticipate and manage emotional and mental health crises?
Okay. I will not speak of WHO, but I will speak on a different youth hub in WHO, which is called the Global Health Workforce Youth Hub, which is a space developed for us as medical students and other healthcare professionals as well involved to go into an open dialogue and to generate research and evidence about what these unique experiences that these young people and demographics live in who are going to be the prospective healthcare professionals. What I would like to highlight in the first thing is that the educational institutions around the world at the moment do view their medical or do view healthcare students as students that will be in the future healthcare professionals, and they put them at certain environment that is intended to build a resilient workforce. But what we are missing here is the fact is that to have that resilient workforce, yes, one must have the proper skills and competencies in order for them to work in the field, but then the system itself is not resilient. The system itself is not does not offer that organization and resilience that protects its healthcare workers, that provide decent working environment, that as my previous panelists here broke out, we're talking about unequal wages and wage gaps, especially when we address that from the demographic of just an entry-level doctor. It's way magnificent and way amplified in comparison to someone who's in the field for a couple of years. We're talking about issues relevant to mental health, severe burnout, anxiety. We're talking about issues relevant to extreme and high working hours, especially at entry levels as well compared to other healthcare professionals. These are all issues that affect the well-being of the students. And then you know that COVID-19 brought that forward. And now we are left with a couple of healthcare students that are on brink of graduation, and they know what the health system is waiting for them. They know that this is the health system we're gonna operate in, and these are the challenges that we are expecting. But educational wise, am I prepared for that? The question is no, because again, we're taking it from an individual approach. So if I would move it forward from a more of a action-oriented discussion, I would say that the educational institutions need to look at not only the product of you're going to become a doctor, but what type of doctor does the health system needs, and what are the skills that I need to provide you in order to do that, and what are the environment that needs to be available for you in order to be able to operate. And these are the two elements that have to come together, because if one is not there, we're missing here a big picture. I think the first thing that comes into mind is the fact that integration of mental health and well-being into the educational curricula would be one step forward. That you need to take into account, because mental health within healthcare students could be stigmatized. There's not an open dialogue with their professionals around them. There's a fear of the fact that if I speak out about my mental health condition, that would affect later on my training opportunities, that would affect my career progression. And we need to have that dialogue, or that change in narrative, starting from a young age. And that means also educational professionals that are educating the healthcare students. I think another element that comes into mind is the accessibility of services, whether you are healthcare students or whether you are inside the career itself as a healthcare workers. What mental healthcare services are provided to you? What support systems are there to support you if something happens? Is the environment, and as previously explored by my dear colleague here, the management level is supportive with you? Are people able to identify if there is a certain situation going on with my peers here, and I'm able to take an intervention, and what type of intervention that would be? These systems are not in place, because again, we are depending on ourselves to take care of our own mental health and well-being, but the systems are not offering any help, and the systems are not changing in terms of the environment itself. If I would summarize as well, I think something very important that we need to also take in account is the demand that we want from the health workforce. We want a high-level performing workforce to cut into the shortage that we have a 10 million shortage, and that's a huge burden to put on us as students, because we know that we're going into a system that is showing a lot of fragilities and challenges. We are also in a poly-crisis world where there is a lot of different challenges around us. Next day I could wake up to a future pandemic. We have a climate crisis happening all around, and that changes the narrative of me going into the field as a doctor. And that's why not only the support is required from the health system perspective, but at an educational level, these competencies also need to be integrated. So I would summarize that up.
Perfect, thank you very much. Well, that gives us already the perspective that we wanted to have initially for the conversation. Now we go to the audience, and we'd like to ask and to kindly ask questions to the panelists. And we also are getting questions from the Zoom participants, right?
You have one question.
I do. Okay. Yeah.
Yeah.
Okay. And so I got it. So perhaps well, we have a question. So clearly, we have been trying to represent all the professionals here, all the medical professionals, as much as we could, understanding that it is impossible to do it in this fashion. But here's what can people, organizations do to move forward the important work that WHO is promoting? I think that question would fall squarely on your presentation. Yeah.
Well, there are a number of steps that organizations can take, and that's everything from the important advocacy that the IFMSA are conducting to your accurate use of data and statistics. So when we talk about, I'm gonna pick apart a couple of things with your kind permission. Health worker resiliency. No, wrong frame. We talk about people-centered healthcare, and then we expect health workers to somehow in and of themselves be resilient. That's not what we're talking about. We are talking about health systems resilience to provide the right resources to the workers. So let's start with students. Students, take the opportunity to learn about what your work environment should look like and be armed with the ability to ask for those conditions at work. You'll see that nice wheel. That is what international law and treaty, side note on this, that is what international law and treaties say that you have the right to do in your working environment. Now I'm going to pull back from this. This is what's called non-binding. What that means is we all agreed, most of us agreed, but we didn't tell ourselves that we absolutely have to do it. So it's going to take advocacy, it's going to take hard work, it's going to take coalitions to make this happen. But the overall idea is this is what you deserve in your working environment. You need to take this forward when you go into a work environment. Now, you mentioned the 10 million gap, so that gets to a nice part, which is data, which is progress, which is hope. In 2016, when we launched the Global Strategy on Human Resources for Health, there was a projected 18 million health worker gap by 2030. That is now 10 million. That's good, right? It's because we're using data well, and then we're going to take the reverse of that. What's interesting to know about that is 2 regions are bearing an increasing disproportionate burden of that shortage. But it shows us that if we apply strategies, if we invest, if we use good management, then we can make a dent in that shortage, which in turn is going to make your working environment better. Same thing for, and I'm sorry to do this, I'm going to pick apart gender for just a second because there's some really interesting data that's the perfect place to discuss. 67% of the global health and care, 67.2% as a matter of fact, of the global health and care workforce is female. Now, what's interesting about that is it was 70% about 5 years ago. But again, we could say, have we made progress if we're getting a different percentage? And my colleague Michelle's report on the gender pay gap, which exposed that equal, absolute. So Juan Carlos and I are, I would say, more or less peers. In the same working environment, same experience. I've taken no time out for maternity leave. We got the same exact education here, and it's 24% more than me. So let's think about that. Let's think about how we change those dynamics, but we need to be precise about what that means. It doesn't mean that if I took 6 years out of the workforce, then I earn less, ergo I have less experience. It means we have done the exact same thing through our entire career. We got the exact same grades in school, and there's a difference in our pay. So that's interesting. So we need to be precise about what we are presenting and what we're dissecting, and we need to be precise about what that means. So the 70% gender pay gap is actually a really interesting area, because you'd assume that if the balance is shifting, then that's better. Not always. You talked about decent pay. Community health workers, more and more of them are getting paid because we have been making wonderful, positive efforts to advocate for pay for equal work. As you start to pay a community health worker, who also wants that job other than the women who've been doing it for free? Men. That accounts for some of the interesting balance of what we're seeing. So there are pluses and minuses, but we have to be really smart about how we interrogate the data, how we evaluate strategies and approaches. We have to start from students being able to advocate for their rights. Academic institutions doing academic institutions incorporating competency-based education in their programs to give health workers the right capacities to be able to do their job, including leadership. We have an HRH leadership and management course. You take it online. And then it involves organizations, employers. How are you creating the decent work environment that allows you to preserve your health workers, that keeps health workers from migrating to perceived better working conditions that may or may not happen? It could be big things and it could be small things, and Aisha is much better equipped than I to talk to some of these specific interventions. But I saw an interesting element right now. I'm just going to put this out for employers. Last week, I read an article that the NHS is now allowing nurses, who comprise 59% of the global health workforce, they are allowing nurses to have tattoos and facial jewelry. Now, what difference does that make, really? It's recognizing an autonomy for the workforce. I personally don't want to see nose rings, but it's none of my business. If it doesn't impair somebody's ability to work, I no longer have to wear 2 layers of clothing and I can show my tattoos. That is an example of a workplace looking at a smart intervention that allows them to show caring, interest, and accept feedback from their workers. So
Yeah, we have another question, sorry.
Sorry.
Thank you very much, and frankly, I didn't know this thing about that too, that's quite interesting, I thought they were pervasive. Madam, you have.
Thank you. My name's Jacqueline Dunkley-Bones and I'm the Chief Midwife for the International Confederation of Midwives and previously the National Maternity Safety Champion to the Secretary of State for Health and Social Care in England. I have a few questions for the panel. I haven't heard very much about equality and diversity, and there's a lot of data about ethnic inequality and inequity, and it would be really interesting to get your take on this. Secondly, I'm looking at this model with interest, and it looks like great guidance, so we're really keen to read more about this. But I've been around for about 3 decades in health, and I've seen models like this in the past. And what I'd like to ask is, what confidence do the panel have in this being implemented and sustained? Because many of the problems, if we look decade to decade, they just go around and come around, and we make incremental gains, which is great, and some people benefit. But there are some fundamental challenges in relation to nepotism, cronyism that happens at all levels of society, HR systems that belong to chief execs and their people. And so how are we going to move the dial? So this looks great, but I'd be really interested in what the panel think about the confidence in this being implemented and sustained.
Perfect, so I think you are asking 2 questions.
Yeah.
One has to do with the equity and diversity, equality and diversity, and the other one has to do with the confidence we may have in having a model that actually delivers what it is promising. So.
Very interesting question. And I think one of the things that I would strongly suggest is to have not go with national numbers when it comes to health workforce. The more granular you'll have the statistics, the more you'll be able to get the insights onto that. So as we propose gender disaggregated data, we should be looking at age disaggregated data, we should be looking at ethnicity, and we should be looking at urban, rural, all sorts of disaggregations at national, at regional levels to get better insights into that. We should also have it by our important cadres. So nursing and midwives and like in our country we have lady health workers. They all have their own dynamics. They all have their own challenges, and they are part of the health workforce, and particularly those who are at the front line. So we can't club them all into one, and this is the critical shortage. It has to be dissected. So I think it's a very important point that you've raised, and that's that when we do, we all do human resource for health profiling, so that's for every country, because there are very few HRH observatories. So we tend to do that, but as disaggregated that we can get, I think that is something that we can use to build up investment cases, based on that disaggregation. So thank you for bringing that up, even the religious ones and all that. So that's important, because all of them would have a different social construct, a different set of, these factors playing onto that. And your second question, I think, which was, sorry, what was the second question?
So the second question has to do with
about
the
this,
model.
In my experience, because I work with the government, so every time I went to the secretary and I said, I'm making the health policy, the 6 building blocks, he would just start looking in the other direction. She's come as a consultant and the 6 building blocks. That's the job of the technocrats, to try to understand how these models are used and try to get the information from the, decision makers, policy makers, and tell them what are the drivers and how can they impact. So I think that conversation is very important, how we translate that into conversation for better understanding of policymakers. The technocrats will understand it very quickly, but they wouldn't, and they wouldn't even have the time. So having worked for the Prime Minister office, his attention span was never more than 1 minute for every agenda which was coming in, So what would you tell him in that 1 minute, which will be important for him to say, okay, we are doing this, the 5 things that you've told us, and we'll give you money for that, So I think that as a technocrat, we have to take responsibility of translating it for those decision makers and making sure that the wealth of, effort which has gone into developing these is implementable. So that's the job of the technocrats.
Thank you very much. And we're going to start speeding up a bit, just in order to recover some time so far. But we have a couple of questions for you. So one is, how do we struggle to transfer evidence into practice to improve the nurses' working conditions? So we have nurses in the audience, and we know that as the type. We very appreciate it. Sir?
Yes, if I can even answer that, or at least give some rationale to that. I'm nursing research at the Berlin University of Applied Science.
Sorry, your name?
Christoph.
Christoph.
And we do research on the working conditions on the nurses. And I would highlight 2 things on that. One thing is the incentives or the aspects that are seen on the different levels. For example, burnout is directly seen on the board, how the people behave, how they act, how the decision makers have other kind of data they use for decision making, like filtration rate, some data that is long behind the stress reaction or the situation which leads to this burnout. So their data they use to make a decision is always a bit too late on making that measurement. So I think it's crucial to, when we discuss about transferring theory to practice, to discuss about on which level different they talk with each other. And the other aspect is what we heard from the panel is that we a lot of often request managers to implement measures, and what we miss also to think of their situation. So this managers, they need to manage, and what we know from research is that because of their stress situation, they do not have time to invest in, have no resources to focus on working conditions. So they prioritize from their perspective on the outcomes they need to achieve from the CEO to increase the costs. And therefore, when we discuss about taking measures, I think it's important not only to point on the managers to make any changes, but also to point on the upper management level to allow resources for the management from the lower and middle management to make changes.
Thank you very much. And so we have another question for the audience. We have heard multiple perspectives from our panelists, ranging from the public sector to global NGOs and quasi-private institutions. Based on your experience, do private, non-profit, and public sector institutions have different approaches to managing provider well-being? How are these different? And reflected, how are these differences reflected in what are the implications for developing a holistic solution to the crisis? Should I repeat that? Perhaps, right? Oh, it's there, so you can claim me. Sir.
Yes, I would like to chip in. My name is Kenneth Ogendo.
Sorry, say it again.
My name is Kenneth Ogendo.
Oh yeah, Mr. Ogendo, thank you very much.
Yes, from Kenya. I work for Rural Community Alliance. And I really like what the panelists have discussed, and I just want to give perspective based on the question that you have just asked. One of the things that, if I give you an example of what's happening in my own country, if you've been following global news, you have seen that Kenya is just coming from a 60-day strike, and our medical doctors were on the streets for a whole 60 days to champion for their own rights. One of the things they were actually clamoring for was the payment of the interns. And the interns were earning around 206,000 shillings before the strike. And they were supposed to get their money reduced to 70,000, agreeing with you on the inequities that are there. But now the interesting thing is, just to show you how multifaceted this thing is, the other healthcare cadres, from nursing, clinical officers, public health officers, community health workers, were also asking, we also need to be paid as interns. So you find we have a huge premium that is put on medical doctors, and we don't have a similar premium put on public health professionals. And we saw the community health and public health workers joining those conversations, piggybacking on the doctor strike so that the health system can respond to all the problems at once. So you'll find the public sector has not been able to absorb the number of interns that are being produced by the government. We have so many medical schools that are coming up, so many public health schools that are coming up, and we are not able to absorb the number of healthcare workers that are being produced by the country. So interestingly, we therefore need now looking at solutions. How do we combine the public and the private sectors to see that we are producing people who can be absorbed by the system? Then another challenge which I would like the panelists to also discuss, how much money is put into mental health? Even before we look at the mental health of healthcare workers, you find we commit less than $1 per capita in our country on mental health. The COVID-19 pandemic exposed the ugly head of mental illnesses. We thought that we were healthier before, but only COVID to make us know we were actually sick all these years. So we are not shining light into mental health illnesses. But even after that exposure by the health systems globally, we still have very few governments that are putting money into mental health. So we are working with community health workers, like the one who is there with me. We are trying to see how can they be involved, how can they be supported, so that you can have more money going into each household receiving mental health services at the last mile. Because we are all sick, just as the degrees are varying when you look at mental health. But again, if the healthcare system cannot invest in mental health as much as you would want, then how much more will the healthcare systems invest in the mental health of the health workers themselves? Because it is very easy to put money in HIV, TB, and all the big things that you can see that are tangible. And so I feel the conversation, and it's great that you have WHO here, we need to have more investments in mental health, and have that trickle down to more investments for mental health for healthcare workers from the health system perspective, moving into the health workers themselves. So I find there's a disconnect there. So before you get there, how are we investing in mental health as a health system? Yeah.
Thank you very much, Mr. Ogendo. Well, we continue in our conversation. Now we have a question for the panelists. Actually, a couple of questions. So, and I'm sorry for this weekend, for this rapid fire. This is just to make sure that we actually hit what is a rich agenda. Two questions that we have for you, and the first one is: do you perceive a tension between the needs of healthcare organizations, healthcare workers, and patients? We already have kind of associated with that tension. If so, how can we address this issue to ensure that we are adequately supporting and caring for those who are responsible for patient care? Remember, the idea of this conversation is to focus on what is being implemented as solutions so far. So we can have a couple of answers from the panelists. We have, by the way, I have to introduce, sorry about that, and Dr. Beverly Johnson. She comes from Ottawa in Canada. She's from WGH, and she's a family physician, co-chair of WGH Canada, and she's the president of the Federation of Medical Women, who advocates on wellness for primary care providers. So Dr. Johnson, and that is something that perhaps you can help us to illustrate.
Sure, absolutely. So maybe I'll just set the scene a little bit here as part of the answer. So there's evidence, and this is the report that was mentioned earlier by Dr. Hamez on the Great Resignation and the Great Resignation from Women in Global Health, which can be found on the website, that countries with the highest burden of disease also have the lowest density of the health workforce. And also that at least 6 million workforces are unpaid and grossly underpaid in core work systems. And so also the frontline health workforce, predominantly women, continue to deliver essential life-saving health services in challenging operating environments and are often the only healthcare workers accessible to a vast majority of the population, particularly in low and middle income countries. And maybe the final comment, just setting the stage here, is over the past few years, we have seen massive internal displacement in countries like Palestine, Afghanistan, Iraq, Somalia, Syrian Arab Republic, Yemen, and external displacement in Jordan and Lebanon. And so there's a huge demand on health services and national health systems. So with the critical shortage of healthcare workers, low production capacities, and the unmanaged migration of health workers, it just exacerbates the situation. So yeah, so just some of the scene here. So so women only hold 25% of senior decision-making positions in the health sector. And so there, to enable the gender conduciveness of work environments and an introduction of gender sensitive workplace policies, we really need more women in leadership to allow for wellness programs. So flexible work hours, availability of daycare, and ensuring the safety of female health workers. Yes.
Thank you very much. Yes.
Information.
And again, the idea is that if anyone wants to contribute with this point, really appreciate and Dr. Malik.
I'll just do a quick jumping, because I want to segue to the colleague here that made the point, which is
yes.
only, on average, only 2% of government's health budgets worldwide goes towards mental health, but mental health is about 50% of all of health, if you think about it that way. So we are massively underinvesting in every country. And so you make a really fine point of, if we already have limited services, why on earth would those services go towards just one member of the population, which is the health workforce? And this is where the advocacy issue comes in. And that's down to us, that's down to you as well. We lose about $1 trillion globally every year because of anxiety and depression. We know anxiety and depression is higher in health workers. About 12 billion sick days are lost every year because of mental health conditions when it comes to people who work. So you cannot have a sustainable healthcare system if you do not have a healthy workforce. And this is just part of some of the items that go into advocacy. Now, what we've started doing is we do mental health service development in general in countries. We're now always saying, okay, we're doing this service development for the population. What about the staff that are actually working here? So it's becoming part of our conversations as part of service development work, but it's also becoming part of our conversation with donors. If donors are giving funds to do something in mental health, have you included a budget item in there for staff mental health as well? So it's very tiny steps, but it's a really fine point of there is massive underinvestment in general for all members of the population when it comes to mental health.
I might just come in with a few statistics as well from the work that we've done and others on return on investment. So if we look at the reactive piece, return on investment for access to an emergency employee assistance program or something like that, about 3 to 1. When you look at organizational inputs like training of managers, all these sorts of things, about 5 to 1. But then when you look at prevention, actual putting the structures in to stop these things happening in the first place, it's about 6 to 1. So it's one of the biggest or best investments that you can have. And that's one of the ways that we would go to an organisation to explain why they need to do something about it. Now, to go to the gentleman from Berlin's point about managers, that's fascinating, because when we looked at across the data that we've done across multiple sectors post-pandemic, we were quite surprised that the one group that seemingly needed the most support, that were the most pressured throughout this, is actually the management group. We'd expected the blue-collar workers who were profoundly affected during the pandemic in terms of their inability to work and the loss of earnings, etc., that led to be the most affected. But actually, no, the managers, and this is across sector, not just healthcare sector, they're the ones that are expected to put all this stuff in. They've got all these impositions from the board to do stuff for mental health. It's all very stressful for them. And they are, so I think that's a really interesting group to focus on.
Sorry. Okay, you were about to add. I know it's an idea.
Jump in. May I jump in?
Yes, please do.
I'm actually gonna segue back to this question because in a recent focus group that we had with our members in IFMSA, we've asked them exactly something similar to this particular question. And we've noticed that most of them, they come or they are educated and they have a strong belief that they want to give back to the patient. But at certain times, the limited available resources that is present, the current setting or working environment they are in, put them at situations where they are at the front line and they are the one that is facing the displeasement and displeasure and that comes from the patient, and that creates a certain tension. And then the role of the management in that particular element is that the people that take that blame are the people that are the front line, aka the healthcare workers. So if there is a need to address the particular issue, I would say that it comes from the fact that you need to first address the available resources or the lack of available resources that is present at the working environment. You need to have some sort of not an education, but an awareness level that these healthcare workers know how to handle difficult patients, and these patients also are coming from a place where they need an access to that healthcare services. So the management need to act as an intervention, not to allow the front line to handle this point of tension, but the management need to interfere at this particular point and to offer the adequate support needed for healthcare workforce and also the adequate support needed for patients themselves.
Thank you very much. So I still have a question for you. So that's also the reason to get this a bit rolling. As we were preparing for this panel, we discussed the necessity of our health system to be human-centered or people-centered. That's perhaps a lack of better definition. Perhaps focus on centers on rights rather than solely patient-centered. That has been quite useful. That mantra has served quite. I mean, it's more like a target, like a value statement. Now, how can we ensure that we maintain a holistic view that supports the well-being of healthcare workers while also improving patient and community health?
I'll start with changing the dialogue. So maybe to take an example, you talked about the workers striking in a continent where 1 in 3 graduates fail to find work. That's a labor market imbalance. That means that the educational institutions aren't talking with the job market, with the health sector about what and who's being produced. Now, Aisha made an interesting point about the amount that's spent on mental health services. How many of those graduates who are striking were mental health professionals?
Wow.
It's an interesting thought. I'm just dropping a little piece in the bucket there. Because when we talk about production, you need to base it on something. You have to base the salaries on something. Within WHO, we offer the tool of the health labor market analysis that pegs the educational inputs into what someone is paid on the job market equally for all genders and races and ethnicities and identifications. So we will help countries, we will come and help countries figure out what a fair pay is for each of the health workers. We will help the educational system to rationalize the production of the health workers. And we need to change this dialogue about how much it costs to take care of it and start looking about at how much it costs not to take care of things. How much does strike time cost? How much does time off work cost? How much does it cost to retrain somebody as a medical doctor? How much does it cost to retrain a nurse when people leave the profession? We need to start to think a little bit less about how much are we paying and how much are you putting into economy? What are the gender gains? What are the labor market gains? What are the social gains that you get in communities by creating employment, by creating decent work? So we need to start those at the highest level of decision making. When we do that, we need to come with data. We can't expect to walk into a room with our leaders and say, we need money. We're not the only ones doing that. Big sign. We have to be able to come in with the data and with the persuasive arguments and with the evidence of what happens when you put in the right formulas. What happens when you do the right thing? What happens when your health workers aren't migrating to another country? What happens when you do all of those? That's why we need you to work with us to create the evidence, to be fastidious about how we use data, how we create data, how we study together, and how we share it. We need to do cross-country comparisons. Sometimes the way to convince a leader is through a champion. Are we using them? Are we arming our champions with the right language to do this?
Thank you very much. So, Dr. Johnson,
Yes.
1 minute.
1 minute. Okay, just a comment from Canada and what's happening right now in Canada. So I'm a primary care provider, and as the medical students finish and apply for their residency positions, they have choices. For the last 5 years, the number of medical students applying to do family medicine has dropped each year. So, you know, the government pays the healthcare workers in Canada, it's funded. So one would hope that the government would see that they need to then look at the funding of primary care in Canada. They haven't done this yet, and we keep hoping because, you know, there's so many gaps now. We have so many Canadians, millions who don't have doctors. So I guess it's just another, you know, kind of follow-up to what you were saying. We have this example in Canada, and our government isn't seeing this yet. And we just recently had one of our ministers, our federal ministers, make a comment, well, if our Canadian doctors don't want to do it, maybe we'll find doctors from other countries, which of course is the migration issue, which destabilizes other countries. So anyway, just thought I'd add that in here.
Well, thank you, and very important. I mean, this, and I apologize with the audience and with our panelists that we have to actually manage time so stringently, but also giving the opportunity to continue with the conversation. So we would like to get questions from the audience for the panelists at this point. Yes, or
Yes,
please, Christoph.
I have a question for Dr. Andrew Griffin. You talked about different organizations, flu organization, and the one in the middle, they look for the best practice, so hopefully they look for blue ones. So what would be interesting is if we have these blue organizations, what are the rationale for them, what are the incentives for doing it? Because if they are there and the one in the middle should look for this as a best practice solution.
Yeah, that's a fantastic question. So the rationale is same as yours. They want to attract the very best people that don't leave, and it is very different in different industries. In a tech company, it's very much high. You know, they're trying to keep the young, enthusiastic, high-performing people in post for as long as possible. In other industries, it's slightly different, but ultimately, you've got to link it to your organization's goal and strategy. That's really important. And as health people, what strikes me the most out of all of this is that you know, if I walk into a typical company in Denmark, okay, I go to Denmark a lot, I'm just using that as an example. I will walk in, there will be a canteen there with extremely nice, healthy food, with portion control, where there's social eating with employees eating together. Now, that is not a health company, that's pretty much any company I've ever been to there. Right, and there's some really good examples of where businesses are doing this really well. And yet, if I go to a hospital The doctors and nurses have to, if they've got anything to eat at all, which is often the case, they're not provided with anything in many institutions. But if they do, they have to access extremely unhealthy food that's very bad. And we know there's a strong link between the gut microbiome, healthy eating and mental health, just as there is a strong link with sleep habits, with any number of physical attributes. So one of the things that we try and do is tell organizations, don't just focus on mental health, link it to the physical health aspects. And then you can start really, booming and getting a really happy workforce that has a sense of belonging. I think that's the other area that perhaps we need to work on as health institutions, strengthening that sense of belonging and protection. Social connections is such a strong protective factor.
Any other questions from the audience? Sir?
Yeah, just quickly, following from, or rather picking from where we left, I wonder to what extent are we making the social media influence public health, an issue of public health importance, especially in regards to mental health. And I would imagine this is a great place to begin, because you find right now both adults, teenagers and children are spending a lot of time on gadgets. And it has a huge correlation from a public health perspective to mental health. We're not controlling the amount of time you're spending on gadgets. We are not wired to be robotic. But because of the algorithms on all this, I think everybody's aware about that. We all know how addictive these phones are. They excite the mental health, or rather they excite the same centers that weed or cannabis sativa excites. Produce dopamine and other hormones that make you want to keep scrolling and scrolling. So don't you think this is the right time to make this thing an issue of public health importance, so that the globe can start responding with policies that reduce our addiction to the gadgets and to socialize more physically and less on these gadgets?
Thank you.
That is showing our social purpose.
Well, this is kind of a question on the edge, but it may have a relevance for the workers. I don't know, you're the experts.
Yeah, the evidence is quite mixed at the moment in terms of social media and mental health outcomes. It's what we call a double-edged sword. It can both be harmful and it can be helpful. And I'm going to focus on the helpful part, because one of the things we haven't talked about yet is suicide rates in health workers. And so something that we're doing, and something that social media has been very helpful on, is they notice or can pay attention to what content you're looking at. And what social media is therefore doing is trying its best. Hasn't worked successfully in all countries, unfortunately. This is a lot of the learning has come from when things have gone wrong, is making sure that if people are looking at mental health content or content that's more harmful than that it's redirecting them to get support where they need it. So actually something that's been quite positive about social media is many people did not know where they could call to get support in an immediate crisis if they were feeling suicidal. And there's been ways that social media and technology in general has been utilized to do that. So I think that's a positive of technology. And at the same time, we need to understand what are the issues that it is causing, because this narrative is coming up a lot. So that's my attempt to segue it to the health workforce.
Could be either, it could be the interiors could be used for good.
Yeah, both and.
Okay.
We're certainly seeing a rise in social media fueled what we call political anxiety. We've got an editorial out next month in Journal of Occupational and Environmental Medicine on what that means for workforces and employers, because we've known about the social media issues for a while, but now we have the constant stream of news, usually bad news, and that has an impact on productivity in the workforce. It has an enormous impact, and there are things that you can do as an employer to help in terms of psychological support, but also creating the structure to make people feel like they do have an element of control over their lives and their futures, whilst all the externalities are somewhat out of our control. At least if an employer can give some comfort to their workforce that their jobs are secure, that their employer will look after them, all of these things are protective in this sort of fairly new environment that we're just studying at the moment.
Perfect. Well, thank you very much. It's an interesting take, and of course, everything is perhaps connected. That is the complexity that reality brings with it. So we do have a question for the audience. We would really appreciate that others who have not participated actually do so at this moment. So let me ask you this question. Do you believe that the instruments and actions designed and implemented to address the crisis are adequate? The ones that we have discussed so far. And do you see more success than shortcomings? What would be missing? Alan?
I know I've spoken already, so.
So, no, but it seems that you're the one who, no one is jumping, so.
No, is that okay? I just didn't feel that I had an answer to my other question about that amazing wheel. I mean, it looked absolutely fantastic, but I was really hoping to hear from the panel about their confidence in implementation and things being sustained, given that we are a virtuous circle sometimes, producing, developing, testing, evaluating, looking at the impact, and the impact as marginal. And so I know this isn't the finished up, nothing is ever the finished article. I was really hoping to hear from the experts about what they thought about how things would be. You know, I heard from your colleague, it was the it's the technocrats chat problem. It would be like me saying, well, this is the woman's problem. You know, I think it's our problem, and so you've got a lot of expertise. I was interested in the article that you're going to be publishing soon, and so just wanted. And then I'll tell you the question back.
No, actually, that is a valid question. We believe that the instruments. So this your question. I mean, that is an instrument. That is the reduction of reality in the model. Makes us to come up with some trade-offs. So the question is it something that we're confident is going to be helpful in assessing and tackling and solving the problems?
Well, I'll start with the fact that I have to report on it. So, and this is going to end with need your help. So let's start with, we have that will shortly be coming out with a short and a long assessment form. The short one, 10 questions, one for each issue area, that helps organizations, stakeholders, individuals, employers, national governments look at some signal indicators to see where they are with regard to these issue areas. And once they've established that baseline, we have the desk review to look at. We want governments, we want other stakeholders to take these and start looking deeper into, we'll have a longer assessment form. And whether you're interested in attacks on health, which is pretty topical right now, or whether you're interested in gender equity, we would like you to look at this tool as a way to see what the baseline is and then measure progress against it. So some of the ways that we see stakeholders engaging are by taking these assessment forms. Some of the ways are by designing case studies and other research, whether it's in a national context, I'm going to look at all of Kenya, whether it's I'm going to look at ensuring equality across Kenya, Colombia, and Kazakhstan. Choose where you want to look, whether it's across regions, whether it's within a region, whether it's countries with similar contexts, one issue area, a full assessment of where a country stands. Pick your beast and let us know what you're finding out. Be rigorous about the research, but you can submit that research to the Law and Policy Portal. We have a plan to continuously update it. It's, I'll let you in a little speak. Is there anybody from government in here? Okay, well, as WHO, we can't judge governments, we work for them. We also work for all of you, we work for everybody. But we can't judge governments and tell them where they're good, better. This portal is housed at a university. It is open for stakeholders, preferably to take a positive approach of where can we go together. But also to take you need to do better here. We can't have health workers being targeted, bombed, attacked, taken hostage. So it is a tool, it is a starting point, it is an opportunity. And that's what I'd really like to highlight. Anything that we all do, we need to do together, we need to do rigorously, we need to do thoughtfully, and we need to measure our progress and see where we can learn from each other. So I think that's the big area. Do I have confidence? I'd sure like to think so. Most of my career has been leading up to that beautiful wheel. And most of keeping you all in the professions at every point is about seeing that we do this. We have the resources to support. We are developing more resources to support implementation. We need to know what the situation is and where we can strengthen it. And we need coalitions of individuals, associations, academia, civil society, and governments working together to make a change in this area. I am a glass half full kind of gal, so I'm gonna say yes, but I need your help.
Sandra Yerso, President of the International Confederation of Midwives, and I'm based in Chile. I'm also a member of Women in Global Health Movement, past board member of Women in Global Health. So regarding the question that what is missing, of course, coming from a country that is not a first world country, I think that it's really important also to think about maybe open it to the other healthcare professions of midwives, for example, us, but also thinking about the health professionals that each one of the cadres, nutritionists, nurses, midwives, physical therapists, etc. Each one of them has a typical way of working in their areas. So if you want to really gonna start working and highlighting how are they going through these situations, we should really identify each one of them and just talk about each one of them, especially as in my case, in our case that are midwives. Identifying their roles, for example, in the healthcare team, how they work and how they interact, and how they communicate. Because one thing is also how the healthcare work team works now. We have to think that now we're in the year 2024. We don't know what's going to happen next. Another pandemic, and whatever. We don't know, disasters in the world. And of course, it's the moment that the healthcare professionals, of course, they are working together, but we should be really moving towards that. And of course, that means respecting their roles, because there's a lot of tension sometimes also inside the health work teams because of this, because we are not seeing all of them. And also, it's really important that we really, as I agreed with the experts regarding monitoring the mental health of everyone, because we are receiving the students, for example, in the faculties of medicine, and we don't know how they are. As an example, I'm sorry, I'm going to tell an example from my country, that is Chile, but I'm working there at this moment as a director of students affairs, and I'm really shocked because of the student situation in mental health. It's unbelievable. So are we really following the students when they come to the medical faculty, to the different healthcare careers, to know if they are prepared mentally before to come into this area? Because of course this will be an area of stress. They will have to cope with many things, but have to study a lot. And of course afterwards when they become members of the healthcare team. And also some other areas, how do we really make sure that we are assessing the places where the students will go to have their clinical practices, for example? Are we really worried about how this healthcare team are going to receive our students, for example, our midwives in our case? Is it ready for them to be, really patient, to be compassionate when they will be when they will need to ask someone if they are, they need support? So it's also something that's our responsibility. And of course, also something really important, this is management of the situation of harassment. We know that in the healthcare workforce, most of us are women. You know that we just heard the numbers, of course. But what happens with this? This is also we are the year 2024, and we still have these situations. And even and we just it seems that things go on. So I think there's another part missing here. There's of course the legal aspects of this, because of course we could go on and discover who is doing the harassment in a certain area. But what happens afterwards? Usually the one that is leaving is the healthcare. For example, there are many midwives that have gone through these harassments, and they go on and they tell, but they finally have to leave. And these people that will do this, they will stay there because usually their positions are really high, top hierarchical positions. So what do we do in that? Do we do something? Are we, trying to get to this point? And of course, I would think that I'm missing here a campaign, for example, of zero violence. We should have a campaign of zero violence, zero violence in the working places, and of course, the well-being of midwives. In this case, there's us, and of course, accountability in each one of the steps. When are we going to say that it's right? What numbers do we want to have? How long do we want to wait until this is achieved? Because of course it's taking too long, and in my case, I've seen and I have been close to midwives that have suicide themselves, nurses that have suicide themselves, community workers that have done the same during the past years. So I think it's just the time that we just have to stop at some point and really take care of what is the situation, especially for midwives in our case.
Thank you very much. One more question.
Yes, I would like to add something. My name is Carlotta Altmans. I'm also part of the International Federation of Medical Students Associations. And I would like to add something that has also been partly touched on by our complete hour, which is the topic of stigmatization. And as someone who is both affected by mental disorders, but also wanting to go into psychiatry, so wanting to go into the other part of, other side of it, I have experienced myself different kinds of discrimination when I spoke up about it, because I have the attitude of wanting to be an example of showing that it is not that it is very prevalent and that it shouldn't be an issue, but at the same time, from superior doctors in that case have experienced discrimination. So I think it's probably impossible to solve and probably discuss the whole issue without discussing societal structures and realities. And changing society takes time, obviously, but we are probably the generation to do that work. And I would just like to know, either from the panel or from anyone in the room, where we see realistic priorities for interventions to start the work and to reduce stigmatization and to foster more open discussion around mental health problems from our healthcare community or from the young perspectives on that side, or whether there are even any national or global examples.
Thank you very much. This issue of stigma and discrimination is central. It is ironic that it's experienced by someone who wants to actually enter the career to be an agent of change, precisely on the issue that we're discussing. Something to think deeper about and act also about. So now at this point, we have a question for you for the panelists. So sorry, I lost my train of thought. Oh yeah. So sorry about that. At this point, we have heard the opinions of our fellow panelists and questions from the audience, statements from the audience, and we would really like to get in a rather substantiated fashion, very brief and punchy, 5 ideas from each, and 1 idea from each one of you. So can we start with you, Catherine? And so what is your closing idea for this panel? What you want us to take with us?
I need to take 2. I never like to ignore a statement from the floor.
Yeah.
Give me a day of zero violence for health workers. You guys start it, I will join. If it's the midwifery day next year in May, we're in.
Right.
Start it, do it. We'll work with the other professions to get it. My other challenge, believe in glass half full. We're gonna, and I'd like my colleague to actually address your question, but I want to say, keep on with the courage and know that you are on the right path. If stigma is ever going to change, it's not because we're quiet. it's because we're loud.
Okay.
Yeah,
That's clear.
yeah, that's true.
Sorry, fine.
Oh, yes, thank you. Very, very powerful conversation here. And as we move on to the action that we're taking in 2021, Women in Global Health launched the Gender Equal Health and Care Workforce Initiative, which we co-lead with the government of France. And the initiative addresses 4 pillars, which we believe are core to achieving gender equality in the workforce, urging, first of all, to promote equal participation of men and women in health leadership. Second, to recognize the value of unpaid work, most of which is borne by women working in the sector, as well as the importance of equal pay. Third, to protect women workers against violence and harassment, as was brought up here several times. And finally, to ensure safe and decent working conditions for healthcare workers everywhere. And this includes addressing the mental health needs of health workers. And we urge to take action on these 4 pillars to ensure the retention as well as the well-being of the healthcare workforce. Thank you.
Thank you very much.
So my parting comments to you is, mental health is a lever for population health. The workplace is a central part of that. So use that to your benefit. Separating mental from physical health, problematic. They both interact with each other so much. That's really important. And thirdly, data, can't do anything without data. There's some really good examples of how this data is going to be collected from a policy perspective. Also, national groups are doing similar. The Medical Protection Society in the UK, for example, has just embarked on a study with Affinity Work at Health, who's a partner of ours, looking at surveying medical professionals across the private sector, which is completely not studied, and they're seeking potentially to extend that globally, so that we might have a bit of a picture of what that looks like in, especially important for countries that are very reliant on the private sector.
Okay, thank you very much.
I'll try to be punchy, but I also cannot not respond to what's already been said. So most of the work on what we know works for mental health in the health workforce is based on doctors and nurses. And we have a research agenda in the guidelines on mental health at work, if you look it up, and it says we have to know for other cadres, because otherwise we're not going to be prepared for when the next emergency comes. So it's essential, use that as a piece of advocacy. And we say it for other, whether you're a racial minority, a sexual or gender minority, all of this is missing. So that's needed. When it comes to the incoming workforce, the newer, younger workforce, they're more literate in mental health, partly because they've got more exposure and discussion on social media, and we are not prepared on how to support them. So something that we want to think about is in pre-service training, what are we doing to prepare the incoming workforce so that they're ready, because they're entering harsh environments that aren't unfortunately going to change anytime soon, but change happens regretfully with right person, right time, right context. And we know this for mental health, or when there's an emergency. That's the other time that change happens. And for my colleague talking about stigmatization, the most effective way to deal with stigma in any context, especially the workplace, is what we call contact-based interventions, when people meet another person living with the condition. So please keep speaking. Look up the Lancet Commission on Ending Stigma and Discrimination for Mental Health, because it validates all the effective interventions in there, and look up the Global Mental Health Peer Network if you don't already know it, because they are training people to be advocates on this issue. Thank you.
Thank you very much.
If I would go briefly, I think it has been mentioned by previously there, but I would say also give power to those who are silent. I think within
Power to those who?
silent. Give power to those who are silent. I think in IFMSA what we're trying to do is we represent 140 countries, of which is more than over 1.5 million medical students. And we do what we do champion the most is having a dialogue where we are able to extract the experiences, the perspectives from different levels, from different countries, from different scenarios all around the world. And this extraction and these experiences need a platform forward. So I would say always try to give power to those who are silent, through empowerment, through training, give them an agency over their stories, give them an opportunity to advocate at high-level spaces, listen to them, guide them into what they need to do to bring that into the highest policy level needed, because this is what young people at the moment are in need, especially healthcare students.
Thank you very much. Thank you. Quite well. Thank you to the panelists for coming up with a really well articulated set of ideas and in such a quick fashion. So at this point, we will have just our closing statement. I would like to invite you, Mahmoud, so to share with me. Mahmoud is part of Women in Global Health. I know it looks ironic, two men talking about Women in Global Health. It happens. Mahmoud, you have 1 minute. I'll have the following minute.
Yeah, it's very hard to take this space because I think it's better to give space to women to speak, but unfortunately I would be direct, I have to leave. Speaking about the burnout is crucial, is essential, and there are huge gender disparities in it, there are huge racial disparities in it. Intersectionality is a very crucial lens that we should keep it in our minds when thinking about the well-being of the workforce. The stratification of the workforce from the student level to the professional level, from the health workers, community health workers that do not get education and jump into the profession just by either self-education or sometimes by capacity building outside of regularized manner. The health workforce is diverse by all means, gender, age, stratification. Once again, it's very much important that we are intersectional in understanding the needs and the challenges they face in the provision of healthcare, and accordingly designing our systems in a way that respects their needs, respects their rights, most importantly, and ensures their mental, physical health and well-being.
Thank you very much. So first of all, I mean, the wealth of the conversation is honestly wider than I initially thought it would be, and perhaps I'm not as visionary as I thought I was. It covered many more areas that yes, I knew they were there, but in a way I didn't grasp them. An example is that thank you for bringing the issue of the management perspective and the involvement in managers as not just as necessary agents of change, but also as subjects that need also the support that is needed. And that is an important consideration. And again, the idea that the work that has been done is, and I will not borrow, but still this from Catherine. I think it is important that we see the perspective of the half full glass, because things have been done. The idea is that those models have to be tried, because at the end of the day, a model will show whether it is useful or not when we use it. And I don't know if that is also a corollary for this conversation. A model is rarely a finalized product. You actually can't, because you cannot put in 2 dimensions our complex reality. So at the end of the day, it's a brave effort, but it also has a room for improvement. And I think we are called to participate in the improvement of those elements that would serve as solutions for others until someone else finds better stuff, because it does happen. The other thing that also I found quite ironic is we have to invest more in those who actually are deciding to tackle the issue. So that sounds like a platitude, but so what you're saying is something that we already know. So in the systems that I have worked, in the healthcare systems I have worked, usually among the worst paid physicians are those that are working mental health, right? And we take it as things are as they are. Well, not necessarily. Things are what they have become, and we can actually do something in order to change that. Either elevating voices and coming up with a movement that actually stops violence for people, but also movement that makes sure that not just compensation, but the way individuals are treated actually favors the best of us in applying our knowledge and experience. We humans can do wonderful things, also ugly things, but wonderful too. And finally, I'm really surprised. My profession is more in business and economics. That is my studies. I'm a professor in an MHA program. I just can't believe that we're using frames of reference that I learned in school when I was 18. Yeah, long time ago. So when I explain this to my kids, they say, okay, you come from the previous center, and that is entirely true. But the point is that we have the capacity also of changing that. References to martial are welcome. I studied martial way back. The tacit references to Taylor happen here. Taylor is 120 years old. Can we believe that? So I think it's also a call for those that are in the management and conducting research in management to change the approach to this. And I thank you, and I want to thank you, but thank you very much for your participation. And I hope that we continue this conversation. So if we, provided that we have a further interaction on this subject, we do it much better. So again, have a wonderful time, and thank you for your contribution. Please enjoy and just listen to what we have here. There's